Okay, hello everyone. My name is Dr. David Choromia. I'm from Tbilisi, Georgia. Not state Georgia, but country Georgia. It's far away from here. And I want to present our study on 6-month outcomes after treatment with the paclitaxel-coated balloon for benign airway stenosis. Benign airway stenosis is a challenging condition that causes significant morbidity, mainly due to dyspnea and reduced quality of life. Management remains difficult as patients often requires repeated interventions. Paclitaxel is known for its anti-proliferative and anti-inflammatory effects. Therefore, paclitaxel-coated balloon may help. The using of paclitaxel-coated balloon may help reduce restenosis and improve long-term outcomes. The paclitaxel drug-coated balloons have a long history of successful use in vascular conditions. Scanning electron microscopy images from animal studies show complete healing of secreted mucosal epithelium and no toxic effect 28 days after treatment with the paclitaxel-coated balloons. This was a prospective, multi-center, first-in-human study evaluating a pulmonary drug-coated balloons. We included adult patients with symptomatic and severe airway stenosis defined as more than 50% narrowing. Patients were followed before the procedure, at discharge, and at 1, 3, and 6 months. The primary endpoints were safety, measured test freedom from major adverse events at 1 month, and efficacy, measured test freedom from symptom-driven target lesion reinterventions at 6 months. Additionally, pharmacokinetic analysis was done in subset of patients. In total, 50 participants were enrolled across 4 clinical sites, including Georgia, Paraguay, and Panama. The mean age of study population was 48 years. 60% of patients were male, 70% Hispanic, and 30% Caucasian ethnicity. The average body mass index was 31. The baseline characteristics were the typical for patients with severe airway stenosis. The most cases were associated with post-intubation and post-tracheostomy stenosis. 47 patients had 1 and 3 patients had 2 target lesions. The vast majority of the cases involved trachea, accounting for 3% of the total. 70% were located within the bronchus. The mean length of the lesion was 22 millimeters. Over 56% patients were classified as Mayer-Cotton grade 3. 7.5% grade 4, and importantly, no patient had grade 1 stenosis. On this slide, I want to present to demonstrate the procedural steps. The baseline image shows post-intubation critical tracheal stenosis. The first step of the procedure is mechanical balloon dilatation, keeping balloon inflated for 3 minutes. We measure airway diameter using fiber measurement probes to ensure the appropriate sizing of the balloons used during the procedure. We use laser resection to make radial incisions. After adequate preparation of the lesion, we proceed with the paclitaxel-coated balloon, also inflated for 3 minutes. As shown on the image after DCB application, the airway lumen is visibly enlarged and characteristic white spots are visible on the mucosa, detecting effective drug delivery. May I use here a laser pointer? Here. So this image after DCB application, and these white spots, which indicates the drug delivery. The follow-up bronchoscopy images demonstrates the sustained results with well-maintained airway lumen at 3 months and continuous patency even at 1 year after the procedure. We achieved 100% freedom from major adverse event at 30-day mark. All 50 patients reached this endpoint without any complications. Now, regarding efficacy, we evaluated freedom from symptom-driven target lesion reinterventions at 6 months with success rate 94%. The significant clinical improvement was observed across multiple outcome measures. According to the Mayer-Cotton grading, every grading system, there was significant, statistically significant improvement at all follow-up points compared to the baseline. Similarly, the MMRC dyspnea score showed significant improvement. At 6 months, 81% improved at least more than 1 grade, 15% had no change, and only 4% worsened. Also, spirometry results demonstrate meaningful functional improvement. At 6 months, 65% of participants had increased FEV1 by more than 100 milliliters, 27% had no change, and 8% worsened. Also, we observed improvement in quality of life based on SF, physical and mental component scores at all follow-up time points. Pharmacokinetic analysis included 70 participants, 170 samples, and showed minimal systemic exposure to the paclitaxel. Only 2 participants had measurable levels, and these levels were extremely low. And importantly, no paclitaxel levels detected in plasma after 24 hours. There were no device-related serious adverse events. However, we observed only 3 procedure-related serious adverse events, including respiratory distress, COPD, exacerbation, and tracheal stenosis. On this slide, I would like to demonstrate the representative case comparison between DCB treatment and non-DCB management. The upper panel shows the balloon dilation of a nearly completely obstructed right upper lobe bronchus here using DCB. And at 6 months post-intervention, as you see, the airway remains widely patent and no significant evidence of restenosis. In contrast, the lower row shows non-DCB case. Pre-intervention image demonstrates the severe tracheal stenosis, and despite the maximal dilation of stenotic segment to the normal tracheal dimensions using laser ablation and balloon dilation, but without paclitaxel-coated balloons, the 6-month out follow-up reveals recurrent stenosis. In conclusion, the treatment with paclitaxel-coated balloons showed the low rates of reinterventions, the significant improvement in airway patency, no device-related serious adverse events, and no systemic safety concerns. Patients also experienced improved symptoms, better lung functions, and enhanced overall quality of life. And finally, I would like to thank all investigators, collaborators, and supporting organizations who contributed to this study. Thank you.
Thank you for this study. I actually have, as I'm thinking through it, I'm having a hard time jumping to the belief that the deposit just over 3 minutes is enough. How are you going to answer that?
Good question. So at the beginning, we have 1 minute for this procedure. We planned only 1 minute, but it was empirical, until we collaborate with anesthesiologists first of all, and we see no complication at 2nd minute, no complication at 3rd minute, so we increase this time to the 3 minutes, and we improve our results for this ballooning. And it was After, I think it's next procedure. From the next procedure, we used all the time 3 minutes. It was very normal for us, for anesthesiologists and for patients. Yeah.
It might be interesting to do either a treat and resect or in the same patient if you have multiple sites to lend credence, because again, I'm having a hard time for something that's going to just be topical unless there's another way that you're getting it into the deeper mucosa. But clearly, it's not going systemic, which I think is great, but I would like to understand how the drug is able to do that in just 3 minutes. That's what I'm.
No, drug works after 3 minutes. It's not related to the only 3 minutes. The drug remains which time after procedure, not to wash, not to touch, and it remains. And I want to tell that the main effect, main result for the after the study, from our experience, is the continuous pattern of airways. It's the most important. The first procedure performed on the patient, we were very careful, no laser resection, no. It was unknown for us the first time, and we opened. It was a young patient, and we opened his he had severe post-traumatic tracheal stenosis, and we do maximum 6 millimeters. It's very small hole in trachea. It's very small, but we remained it, and after we have even 2 years follow-up now from this first patient. But there is continuous patency, and he feels fine. Unfortunately, he cannot move. He sits in his chair. But in case of healthier patients, it's difficult. They experience stridor and difficult shortness of breath. But for this patient, till today, after 2 years, he has continuous 6 millimeters at the beginning, and now after 2 years, he has 2 millimeters. Do the paclitaxel. We are pretty sure that it's due to paclitaxel. No other, because I have a lot of experience doing tracheal stenosis in various different ways, and as usual, we have restenosis more than 50% cases, especially in young patients. And it's very difficult to manage this patient. Sometimes we do repeated dilatations up to 1 year, 1 month even. Every month we have patients, we do it every month. So for me, it's very effective. Yes.
Thank you very much.
Thank you.
Next, we have Dr. Gonzalez speaking about real-world outcomes of nebulized lipophosphates.
Hi everyone, thank you for staying, and thank you for the opportunity to share with you the results of our multicentric retrospective study from Spain and Argentina on inhalant antibiotics.